Today I will discuss about the GI, the hepatology, but in the GI you have to the aspirant have to know the what are the important topic where from the questions come. So first important topic is the upper GI bleed, obviously. If you consider 100% about the GI, then you will get 50% question from the upper GI bleed. Then rest 50% question, rest 30% question you will get from the acute hepatic failure, and few more question from the hepatorenal syndrome. So GI, upper GI bleed, one of the important area where they can ask about the management, they can ask about the different scoring, and they can ask about your knowledge about the management and the different devices. So, first question is regarding the initial assessment of and resuscitation patient with acute upper GI bleed. Following statement apply. So, platelet transfusion is a K type of question. Platelet transfusion is not routine indicated for a patient who is not actively bleed and hemodynamically stable. So option one. Second is platelet transfusion indicated patient who is actively bleed, have platelet count less than 80. Prothrombin complex concentration should be given patient who is taking warfarin and actively bleed. Fresh fusion plasma should not give unless the patient prothrombin time or activated thromboplastin time greater than 2.5 time normal, and recommended factor 7 should be early if possible. So in the chat box, please give your answer. Okay. So let's see what, sorry. The answer is the first one, platelet transfusion, not routinely indicated patient who are not actively bleed and hemodynamically stable is true. And then a platelet transfusion in a patient with, what is the threshold? Threshold is 50,000, not 80,000. Okay. So remember that the second option, it is given that 80,000, you have to start actively bleeding patient in a 80,000, not it is a 50,000. Then prothrombin complex concentration should be given to patient who are taking warfarin is actively bleed. Regarding the prothrombin complex, it is true, and fresh frozen plasma is indicated if INR more than 1.5. Here it is given 2.5. And NICE guideline recommended the recombinant factor A management bleeding where other method have failed. So there are on initially the recombinant factor 7 recommendation was any active bleed, but nowadays it is restricted. I mean, any bleed, but nowadays it is restricted only in active GI bleed or in a patient with active hemorrhage trauma patient where other measures has failed. So now coming to the upper GI bleed, upper GI means it is above the ligament of teres, and uh, you have to remember that upper GI bleed can be coffee ground in form of melena, Sometime there is a frank bleeding, sometime there is a hematochezia. If there is a hematochezia, usually lower GI bleed, but if there is a severe hematochezia, then in severe upper GI bleed, sometimes present as a hematochezia. So don't stamp hematochezia means it is a lower GI bleed. And sometimes you have to differentiate between hemoptysis and the hematemesis. Remember, on the hematemesis, always it is a high volume and diluted blackish, and hemoptysis is coming from the lungs, so it is a more concentrated blood and the volume is less. So source of upper GI bleed is in upper GI tract is 80% of acute GI bleed, and lower GI tract is 20% of acute GI bleed. So type of upper GI bleed, either it is a variceal bleeding or non-variceal. But remember, in ICU, non-variceal bleeding is 80% and 20% is the variceal. So coming to the common cause of upper GI bleed, non-variceal 30 to 50% is the peptic ulcer disease, and 15 to 20% malarious, and the gastritis, duodenal, esophageal, venous malformation, and all that. And variceal bleeding is 90% the gastroesophageal varices, and hypertensive portal gastropathy is less than 5%. So approach to upper GI bleed: immediate assessment and resuscitation, stabilize hemodynamically. But, it is important when you are getting patient in the emergency, you go by A, B, C, D in the assessment, fluid assessment, and the airway, breathing, circulation, stabilize the hemodynamic status, identify the source of bleeding, and if possible, stop bleeding, treat underlying cause, and prevent the recurrent bleeding. This is the whole approach of acute GI bleed. Now coming to this, yeah, estimated fluid and blood loss in the shock. There is a class 2, class 1, class 2, class 3, and class 4. You will get in a general topic also, you will get question from the when there is a question coming from the SOC. They usually ask type of SOC. There is a one, if you see the OS manual, there is one table where by seeing the SBR, the volume status, tachycardia, and there is a 3 4 parameter which help you diagnosis which type of shock. It is one of the favorite area of examiner to ask question from there. And second, this table, you have to identify whether this shock is class 1, class 2, class 3, and class 4. Basically হচ্ছে যে they try to confuse on the class 2 and class 4 type. So management of upper GI bleed: general medical management, type of bleeding, variceal bleeding or non-variceal bleeding. If there is a variceal bleeding, medical management, pressure technique, endotherapy, and surgical intervention. Variceal bleeding, first thing is a resuscitation, start vasopressin or octreotide infusion, confirm the and the endoscopic band ligation or sclerotherapy. If bleeding stop, continue octreotide and complete 7 days of antibiotic. Repeat endoscopic banding every 10 to 14 days until eliminated. If bleeding not stop, then you have an option for tips and the surgical shunt. And tips is basically is bypassing the liver. There is a portohepatic, this is a portosystemic shunt. So portal vein to the your superior vena cava shunt, and it bypass the liver because the main culprit is liver in cirrhosis. It become hard, and the surgical shunt is just grafting. So another important area is the balloon tamponade, the management of active variceal bleed when there is a severe bleeding. You are not able to do endotherapy, then balloon tamponade and since taken Blackmore tube. Sometimes the question come on the Blackmore tube, this three port, what is the utility of the three port? You remember there is a one, two, and three ports is there. So just laser pointer. This three port, one port is for mm, uh, this gastric aspiration port, and also you have to put the weight here. And this is for esophageal balloon. This is the esophageal balloon, and this is for the gastric balloon. So the technique of insertion is just like a Ryle's tube. You enter into the stomach and you aspirate this thing, aspirate the stomach content. If the blood is coming, okay, then you fast filled up the gastric balloon, and gastric balloon it content around the uh, 250 to 500 ml of water, and then there is a esophageal port. So it is very important to know which one is the esophageal port. If you give high volume, like gastric balloon, it's a high containing balloon, high volume balloon, and if you give this high volume over here, then there is a chance of esophageal rupture, and you have to do the manometric check the pressure. Either otherwise it will be the mucus will be necrosed, and you have to do is what I say, the releasing of the pressure intermittently in the esophageal balloon. Otherwise there will be a necrosis.